At the end of this episode, you should be able to define what qualifies a hospital to deliver psychiatric care under New York MHA Statute 939, name the 939 hospitals in our region, name the agency who has primary responsibility of MHA Transport, define the risks of transporting a patient under MHA, describe the appropriate use of restraints, and describe the characteristics of patients who may be transported to St. Mary's under MHA.
So a 939 hospital is a hospital that has the capacity and the ability to provide psychiatric care and treatment. So it's a hospital usually that has an inpatient psychiatric facility and a psychiatric staff on site available to evaluate and treat the patient. Those are, like you mentioned, facilities designated as 939 facilities. And in this area, Strong Hospital, Unity Health System, St. Mary's, Park Ridge Hospitals, Rochester General Hospital are the main 939 hospitals in this area because they have an inpatient facility and psychiatric staff.
Individuals that are involuntarily transported under New York State mental hygiene law can be brought to hospitals. Now, there's two types of hospitals under the law enforcement initiated MHAs or the DCS designee initiated MHAs. Those people need to be brought to what's called a 939 hospital. And 939 is just a section of New York State law, mental hygiene law, that delineates a hospital to have acute psychiatric services that they could admit to acute psychiatric units. In Rochester, our three 939 hospitals are Strong, University of Rochester Medical Center, St. Mary's, and Rochester General. Now, under a 2209, that is involuntary transport due to dangerousness and incapacitation by drugs and/or alcohol, the individual can be transported to those hospitals, but really more generally, any general healthcare facility, any general hospital. So the other hospitals in the area that don't actually have a psychiatric unit can receive those individuals for evaluation and treatment.
The transport decision is based on a number of different factors. If they have come with papers, 945 papers or some papers, it will often specify which hospital the psychiatrist or those who have called it in want the patient delivered to. You have to take them there, even if they're code red or the patient is objecting, they didn't like the care they got there last time, what have you. If you don't have papers, and out here at least often that's the situation, then you want to go to the hospital, the 939 hospital, that they are receiving psychiatric mental health services, chemical dependency services, or have that continuity of care already with the patient. That is ideal. After that, you go to one of the 939 hospitals that is not code red, preferably at that time, and that's just a little double checking. But you go to whichever one, in pretty much in that order.
A 939 hospital has the resources and staff to receive, assess, and treat patients with acute mental health symptoms. Patients transported under MHA must be transported to a 939 hospital. The 939 hospitals in the Monroe-Livingston County region include Rochester General Hospital, Park Ridge and St. Mary's, and Strong Memorial Hospital, University of Rochester. The 939 hospitals in the areas surrounding our region include the Newark Wayne Community Hospital, Wyoming County Community Hospital, Clifton Springs Hospital, St. James Mercy Hospital, and Medina Memorial Hospital. When transporting MHA patients, go to the facility noted on the 945 paperwork. Transport decisions for other patients should be made according to the REMAC transport policy.
But you are absolutely right that the police officers are the main designated persons to transport a patient to a psychiatric facility, which is important to remember because that's one of the misunderstandings of mental hygiene arrest, is that oftentimes, I shouldn't say oftentimes, but sometimes patients are transported via ambulance without necessarily the paperwork completed and without a police escort. That creates a little bit of a gray zone and a misunderstanding of the statutes.
The law enforcement agency making the MHA has the primary transport duty. EMS may be called to assist, but should proceed with a police escort.
With an MHA, I always try to establish a rapport with the patient before they come onto the rig, so that I get a sense of what they're like and what's going on. Sometimes the patient is walked out of the immediate scene by, in our case, the deputies. And so I always make sure to have a little conversation to establish that I am not the deputies. I'm someone different. I'm going to be transporting you. This is what we're going to do, and give them some sense of what's going to happen when we get on the rig. I'm also trying to not be the bad guy, be as neutral as possible in my role, and to be respectful, smile, engage, and be understanding that these things happen. I'm also testing. Are they going to answer me rationally? Or am I going to be able to engage them? Am I going to be able to make eye contact and get them to answer my questions, or am I going to get the silent treatment, which is more difficult to assess how safe we're going to be. Often I will have my partner actually put the patient on the gurney and secure them there, explain what's going on, while I have a quick discussion with whoever the arresting officer is to find out why it is that they've had this mental hygiene arrest, what the circumstances are. Again, giving me more information that I can use to determine safety. If there are any concerns about the behaviors, and often it is kind of that explosive patient that hasn't decompressed from whatever was occurring, that you want to be most concerned about, especially if they have the potential, you think maybe have some drugs on board. And again, then you have a secondary assessment there about whether there's some medical concerns, making them less predictable. You want to have a conversation about whether or not the law enforcement needs to ride with you in the rig, follow what the rules are going to be. As with any potentially unsafe scene, you always want to be aware of where you are as compared to an exit, to have a strategy with your partner. Crew safety needs to come first. So there's no music, you turn down the blowers on the air system so that your driver can hear what you're saying in the background. It can hear if your voice starts to elevate some, and pull over if necessary, those kinds of cues. It has been rare that I've had to do that. Some of that has to do with my particular background, but for the most part, I have found that most of my mental hygiene arrest patients, we can kind of settle them down. All of our lights double switched. If you turn lights down, often patients will respond to that, and they will also calm. You ask appropriate questions to determine a little bit about what happened, but you also read their response. If they're becoming more agitated, you have to make a decision about, is it really worth it to continue to agitate the patient? Often it's not. Can I get this information elsewise from the deputy, or is it necessary really? Am I contributing anything by getting more information on the way?
Tips for a safe transport. When arriving on scene, introduce yourself to all the persons there. Engage the patient kindly and professionally and inform them what will happen next. Discuss the circumstances surrounding the patient with law enforcement present, and make changes in the ambulance to optimize communication with the patient and your partner.
In some cases, it's going to be important to appropriately restrain an individual under MHA. The appropriate type of restraints is a negotiation between law enforcement and EMS in a good way. EMS may restrain a patient when it is medically appropriate, and medical restraints are very different than law enforcement restraints. Medical restraints are what most folks know. Backboard straps or gurney straps are medical and safety restraints. and those may certainly be appropriate. Cravats or soft restraints are appropriate medical restraints. In some circumstances, law enforcement may be significantly concerned regarding the patient's stability, or they may also be under arrest for non-MHA reasons, possession, weapons, what have you. In those circumstances, it's important to have the conversation with law enforcement as to whether or not those restraints are necessary, and specifically with regards to handcuffs. Generally, EMS providers should not be transporting someone in the back of their ambulance who is handcuffed unless there is a law enforcement provider in the back of the ambulance with them, because handcuffs are not medical restraints, and it is not our responsibility as EMS providers to maintain that restraint in law enforcement custody. Should the patient condition rapidly deteriorate, should the ambulance be involved in a motor vehicle crash, and so forth, the presence of a law enforcement restraint may inhibit our ability to take medical care of the patient and then put us in a very, very difficult position. So in that respect, it becomes both a patient safety issue as well as a medical care issue. So generally, whenever possible, an individual, if they are being restrained, should be restrained using soft restraints. If law enforcement feels very strongly that handcuffs are still required, then I believe it's very important that law enforcement accompany that patient to the hospital. Different EMS agencies should engage in that conversation with the law enforcement agency within that specific jurisdiction, whether, at least in this area, it's the sheriff's office or a town or village police department. So anytime someone has handcuffs in place, and for example, someone is being transported to the hospital in the ambulance and law enforcement is riding along and the patient is handcuffed, ideally handcuffs are placed to the patient's front. Any type of restraint towards the back in the seat causes two problems. Number one is that it can limit the individual's ability to breathe. The second is that you cannot adequately apply safety restraints if someone has, particularly ambulance safety restraints, if someone has their arms behind them with cuffs. So placing cuffs to the front, or if necessary, placing cuffs to the front or one wrist to the gurney as a means of disinhibiting an individual from leaving the ambulance.
Restraints should be negotiated with law enforcement prior to transport. Restraints for crew or patient safety should be medical in nature, including cravats or soft restraints. If the patient is handcuffed, law enforcement officers should be in the back of the ambulance with the patient and the provider. Handcuffs should be applied in a manner most consistent with patient safety.
So St. Mary's has a unique setting in the sense that instead of having a full-service emergency department with a psychiatric service attached to it, what we have at St. Mary's is a walk-in care center, an urgent care center, which actually is staffed 24 hours by an MD. And that's also different from your normal or average walk-in care center. And attached to the walk-in care center at St. Mary's is a full-service psychiatric emergency center, which creates a little bit of a confusion and maybe some hesitation on part of some EMS providers. St. Mary's Hospital is a basic life support facility. It's a BLS facility. Patients who are compromised in terms of respiratory, cardiac, significant medical conditions that require acute medical interventions should not be taken to St. Mary's Hospital because St. Mary's is not equipped to deal with life-threatening medical conditions. A good example of that would be your patient who just overdosed. We are not asking EMS providers to bring patients with an overdose to St. Mary's Hospital because an overdose is a potentially life-threatening condition that needs cardiac monitoring, respiratory monitoring, and that person's medical condition can change so quickly that it would not be safe to have them be evaluated and treated in a basic life support facility. However, your patient who is intoxicated, for example, on alcohol, on cocaine, on heroin, unless they are clearly compromised, I'm talking about the patient who's having seizures, the patient whose respiratory suppression is clear on exam. Unless they are compromised, those patients can be treated at St. Mary's and are treated every day at St. Mary's. A patient who has minor bumps and bruises and cuts that need suturing, your average fracture that's without more compromised problems, those patients can be treated at St. Mary's. So I'm going to say again, St. Mary's is a basic life support facility where patients' medical conditions can be stabilized and treated unless they are life-threatening and unless these are compromised patients with respiratory or cardiac problems. Pediatric patients are seen and evaluated at St. Mary's, and we welcome children and adolescents from the community, especially those who are treated in our outpatient clinics. We have a child and adolescent psychiatric service at our satellite outpatient offices, and those patients are better served actually at St. Mary's because we have access to their records, we have access to their therapists, and we can evaluate them and recommend a better course, better treatment option for them because of continuity of care here at St. Mary's. So we welcome those patients. However, one needs to understand that if those patients need inpatient psychiatric treatment, they will be referred to a facility that has that service. St. Mary's does not have an inpatient child or adolescent service for psychiatric care.
St. Mary's is a BLS facility that may manage minor injuries such as lacerations. Patients who require more advanced life support measures should be brought to other hospitals with ALS and psychiatric capabilities. Pediatric patients may be seen and evaluated at St. Mary's. Those patients with existing mental health providers at St. Mary's should be transported there initially if possible. Those pediatric patients who require admission will be transferred after their evaluation to an appropriate facility.